everybody. My name is Sierra, and I'm a student, of course, with the University of Hawaii, Manoa. And my project is called The Look into Intentional Rounding, and I completed it on the unit of Maui East, and my mentor was Mario. So for my topic overview, I'm going to go ahead and talk about the background and significance, the purpose, indicators, a fishbone diagram, the literature review, the process that I went through. Also going to discuss the results and then the limitations and recommendations that I came up with. So for the background and significance of this project, first of all, patient satisfaction and patient safety is kind of the utmost importance. Intentional rounding covers the most basic nursing care that we should be providing to our patients. So their safety and their satisfaction is really important. Those satisfaction surveys are beginning to gain more and more importance within the hospital. The surveys, there's JCO requirements, HCAP surveys, as well as Press-Ganey scores. And it's important because consumers of healthcare are able to look that information up online now. And we only have one hospital here, but as we get a lot of tourists, visitors, and then we do have the local population, people are able to access what the reviews are. And then also some of the reimbursements are now coming from some of our survey scores. So it's really important that we're keeping up to par with that. There are potentials for inconsistencies in intentional rounding, and that could be in either the practice of intentional rounding and the process of the way that everyone is doing it. It could be the frequency of intentional rounding, how often it's being done, and also in the documentation of intentional rounding. So there's definitely some areas that can be looked at. So the purpose of my project was to assess the current intentional rounding procedures and the perceptions thereof of intentional rounding on the unit. It was also to determine the potential barriers and perceived barriers by the staff. And it was also an opportunity to provide education for the staff on the unit. Indicators that were chosen is having improved consistency of intentional rounding in the process and the practice and documentation, improving patient satisfaction and safety through aspects of the process, and improving the education of the staff. This is valuable for both the staff that is doing the intentional rounding and then for the patients that are the recipients of intentional rounding. So here's the fishbone diagram, and most of us use this as a way to establish how we wanted to move forward in our project. And the end point for my project being consistent use of intentional rounding by staff. And this includes the different aspects that kind of can get us to that point, different concepts of it. In terms of a literature review that I gathered, there's two different areas that showed benefits and outcomes for the intentional rounding, and they can be staff or patient. Staff outcomes, you'll find improved job satisfaction and improved efficiency. And staff found the improved satisfaction for a couple different reasons. One is that nurses feel good in general when they can check off a list. And intentional rounding, it can be repetitive and follow a certain system, but it kind of feels good to know that you've met all the patient's needs, and by doing it in that order, it improves satisfaction with the work that you're doing. It also improves efficiency. If you're able to organize intentional rounding, you're able to meet all the patient's needs and coordinate it with what needs to be done with the patient. And a quote that I found on this was that time on the floor was not increased, but it was rather distributed more effectively. And that was one benefit that a staff member found about intentional rounding. For patient outcomes for intentional rounding, there was three kind of major things that stood out. Patients experience a decrease in anxiety levels when intentional rounding is done. And this is because they know that the staff is going to anticipate their needs. Every hour, every 2 hours, the staff member is coming around, and although the questions that you're asking the patient can be a little bit monotonous, they know that each of their needs are being met, and that will decrease anxiety levels. Also in literature, they saw a reduction in falls up to 50% on the patients, so that was really important. And then there's a huge decrease in call lights, and that's a patient outcome, and it's also kind of a staff outcome too, because it went from 8 times an hour down to 1 time an hour. So for the patients, that's better. They're not having to need as much. Their needs are being met. and the staff members are not having to respond to 8 call-outs per hour as opposed to 1 per hour. Attached to your handouts on the very back, you do have copies of these. This was the staff survey and the patient survey that I used. And the questions were gathered from prior existing surveys. The staff survey was about 2 pages long, and the patient survey was only 1 page long, and if you like, you can take a look at that. Oh, and that was just to assess current intentional rounding process. So it was a survey, so it did gather the perceptions of the staff and the perceptions of the patient on the intentional rounding process. So I was able to get 16 staff members from Maui East that were able to answer my questions. There was 3 night shift RNs, 3 night shift PMAs, 6 day shift RNs, as well as 4 day shift PMAs. And then also 3 patients from Maui East were able to answer. And part of it being the 3 patients, those were actually the only 3 that were cognitively aware and able to answer my questions, and I'll go into that further. So for the results of the staff survey, I picked out a few of the questions that seemed to have answers that stood out the most. And I start off with this one. If you had questions about how to carry out intentional rounding correctly, where would you go to find the answers? And I got the most variety of answers. 6 staff members said they would go to the nurse manager, 3 said that they weren't sure where to go, and 3 said that they'd go to coworkers. And there was other various answers, but these were the top numbers. And once I looked into it further, I found out that there actually is no policy and procedure that defines intentional rounding. There is one policy that in one line it says that intentional rounding must be completed, but there is no set defined definition of what should be done and when and how often. And then the next question I looked into is, in your personal practice, how often are you able to carry out intentional rounding correctly? And you'll see that I put a star and I capitalized correctly because a lot of the staff members had a hard time answering this question. They found that they're all carrying out the practice of intentional rounding, they're meeting the steps, they're making sure that the patient's needs are met and the bedside table's close by, and they're doing all those things, but it's not always that they're updating the whiteboard. And a lot of them felt that the most important part of intentional rounding was the actual rounding and less the whiteboard, and a lot of the patients don't use the whiteboard anyways and aren't able to read the whiteboard. So with the whiteboard, 8 out of 16 people reported that they do intentional rounding greater than 90% of the time. And when you include using the whiteboard, that number dropped down to about 5 out of 16 people that do it correctly with the whiteboard over 90% of the time. So the next question that I asked was, what are 3 barriers to your ability to carry out intentional rounding? And I picked 3 just because it was a good number in case there was a lot of barriers, but what I found out is almost everybody really only had one answer that somehow said that they were busy, they were short on time, or they just had time conflicts, which meant that it's not that they weren't doing the intentional rounding, but it was hard to do it on the hour when they were supposed to. Sometimes it was a little before, a little after. Next question is intentional rounding beneficial for the patients and why? And fortunately, all 16 out of 16 said yes, they think it's beneficial for the patients. It allows the staff to anticipate their needs before being called. It increases patient safety. And for this unit in particular, it's important because they're a high-risk, cognitively impaired unit. These are a lot of patients that aren't going to use their call-out when they need help. They're maybe just going to get out of bed right away. They're not going to know when they need certain things. They're more at risk for dehydration or whatnot. So intentional rounding, particularly for this unit, the staff pointed out, is very important. And another question, is it beneficial for the staff? And all 16 said yes. It decreases call-out use, it does save time, there's less paperwork involved when falls happen. And I got that answer from quite a few people. So when a patient does have a fall, it requires a lot of extra work by staff members. 2 out of the 16 did point out that sometimes intentional rounding isn't beneficial. The documentation can decrease the time that's spent with the staff, and mostly nurses feel like there's already so many things that have to get done during a shift that they find an increase in anxiety level when there's something that to them is basic nursing care that they all meet, but now it has become this official thing that they have to do and check off and write it on the whiteboard, and ultimately that does increase the anxiety levels and feel like there's a lot more requirements by them. And then next was the patient survey, the frequency of being attended to. There was 3 patients that answered the survey question. One said that the staff comes hourly, another patient said that the staff comes every 2 hours, and then the third patient said it's less than every 2 hours. What was really important to mention about this, though, is that these 3 patients are fairly independent in the sense that they know how often they want to be checked on, they know how to get their help, they know where to get it, and they don't necessarily want to be checked on every hour. 2 out of 3 patients reported that staff keeps the whiteboard updated, but this is also really important to mention that 1 out of those 3 has a visual impairment, so the use of the whiteboard is irrelevant for this patient, and they had no feelings about it one way or the other. And then all 3 patients reported that their pain was very well controlled, all of their toileting needs were addressed regularly, and they did receive help, and ultimately the staff attends to their needs adequately, and they felt very satisfied with their care. So there's 2 major limitations noted to my quality improvement project. One is that the surveys are participatory and they're self-reporting, so it really requires that the staff member put in the effort. It's voluntary, and some staff members were more excited about answering and some were not as enthusiastic, and so it becomes a little bit subjective. It does give a perceptions of intentional rounding versus actually following people intentional rounding, checking how often they were doing it, and the process. And then the other limitation is the collection of meaningful data from patients. So the cognitive impairments, the 3 that answered, I hope that their answers were very accurate and reflected their experience, but it's unlikely that those 3 responses reflect the perceptions of the entire unit should they be able to answer. So that's definitely a limitation. It's hard to say for the unit as a whole. Despite this, it's really important to mention that even though there's limitations are serious and it's hard to get meaningful data, intentional rounding is important on this unit because of those cognitive impairments. So it's kind of a plus and minus. So recommendations were made based on the literature review and the information that I gathered. One is that there should be a designation of an intentional rounding representative. There is one nurse aide or CNA that a few people mentioned they knew a lot about the intentional rounding process, but if there was one designated person from this unit and maybe even other units, they could be keeping up abreast of what the Press-Ganey scores are, where they're lacking, where they should be improving, if there's any new changes in intentional rounding or findings, maybe keeping everyone up to date on things like fall risks and who's been, how many falls has there been, and just to communicate with the staff, and then the staff can go to that person specifically if they had any questions. And then my second recommendation is maybe the most valuable one, is that there is no policy and procedure at this time. So a future project could be if somebody created a policy and procedure for intentional rounding, and if anybody had questions, they could know that that's where they should go to for help. It improves quality, consistency, and accessibility for the staff. And a sincere thank you to Maui Memorial Medical Center for allowing all of us to come here to do our quality improvement projects. Judy Kodama and whoever else helped her get us in. There's a few people that I haven't named here. We really appreciate it. Human Resources, I think, worked hard for us. My nurse manager, Mario Ong, and then all the nurses and the aides that helped, and especially Dr. Hanberg, who was extremely helpful this semester with all of our projects. We really appreciate it. Any questions?